Hello, everybody. What you're about to see is hours of hard work, everything you'll need to know by the time you finished MBME 31. I'm not affiliated or associated with the National Board of Medical Examiners. All these questions are completely original, made by me. It's everything you need to know at this point in your prep. So without further ado, grab a bag of popcorn and enjoy the next high yield questions that are going to show up on test day, and I'll walk through every single one of them with you. If you think this is helpful, then like and subscribe. We'll see you guys at the end of the video. Here we go. A 32-year-old man presents to the emergency department with a rapid heart rate and palpitations. He recently noticed increasing fatigue and some dizziness. He's 6'5" and BMI of 21, and there's marked hypermobility of his fingers and high arched palate.
My heart just keeps racing. Started this morning, felt lightheaded, kind of wiped out.
How long have the palpitations been going on?
Maybe a couple hours now. Feels like it's pounding out of my chest.
Cardiac auscultation reveals a blowing diastolic murmur heard at the left sternal border, diastolic murmur, whenever he's sitting up and leaning forward. The echocardiogram is performed and reveals dilation of the aortic root. Which of the following is most likely going to be this patient's heart murmur here? Okay, so what are we thinking? All right, so these symptoms you should recognize as Marfan syndrome. And Marfan syndrome silently damages the heart even before the dissection occurs. So even before you have some sort of a dissection, which is common here, you're going to have a lot of damage that's going to accrue. And so they're tall, hypermobile, they have a history of spontaneous pneumothorax, and those are features of Marfan syndrome. But today he's got the shortness of breath, palpitations, and then maybe he's got like a pounding heart. And also look out for a blood pressure, which could be increasing. Like they might say they have like a 140/55. That would be a wide pulse pressure. And then you listen on auscultation, there's a diastolic murmur on the left sternal border. So what's going on is in Marfan syndrome, you have a fibrillin 1 mutation, and that weakens the aortic wall and it causes aortic root dilation, okay? It weakens the aortic wall and it causes a dilation. And as that root stretches, the valve leaflets, they can't close during diastole. Diastole is the filling phase, right? And they're not able to close, and that allows the blood to flow backward into the left ventricle, and that would be aortic regurgitation, right? Because aortic regurgitation, that blood is coming out of the left ventricle, going out, but because the fibrillin gene is defected, the aortic wall is going to be expanded, and that makes the blood trickle right back down. So here's the blood trickling right back down. Okay, hopefully that makes sense. And now let's look at the bottom line. Aortic regurgitation is indicated by diastolic murmur and aortic root dilation in this patient with hypermobility. Okay, so that one's just recognizing the signs. All right, now we're going to lay the groundwork for our next little question here, which we're calling 27. And I would love for you guys to tell me everything you know about Candida and Chlamydia and herpes and Neisseria and Trichomonas. Tell me everything you guys know about those conditions. You just gotta spit it out, right? That's what I'm gonna do here. Let's start with Trichomonas. Trichomonas vaginalis. So is this aerobic or anaerobic? I like it, Lula. Nice. Is this aerobic or anaerobic? What are we thinking? Trichomonas is anaerobic, and it's a flagellated protozoan. Is it going to be itchy or not? Itchy, dysuria. You have a lot of the disses with this one. Dysuria, dyspareunia. And then how is the discharge looking? Yeah, good. Anaerobic. You got it right. It's green. It's frothy. Malodorous. Okay. This one's nasty. That's how I like to think of this one. This one's super crazy nasty. Very good, Lula. Okay. So this one's disgusting, right? And what about our Candida? So Candida, you mentioned some good things. White plaques. Also, they're going to have that slightly erythematous base, and antibiotics are going to disrupt the normal flora, and that predisposes you to Candida overgrowth. Also, sometimes that can cause mucosal irritation and inflammation, so you have like a burning sensation sometimes. Okay, so that's some Candida, and that's kind of how it presents in these questions. And treatment for Candida is going to involve the azoles and nystatin and oral fluconazole. Good, yeah. And then let's talk about another one, chlamydia. What is special about chlamydia? So chlamydia, one of the big things you need to know is that it progresses to pelvic inflammatory disease and causes ectopic pregnancy and also some problems with fertility. And this is just going to have some watery discharge, just watery discharge. So by the discharge, you can distinguish between chlamydia and trichomonas. Okay, so the discharge is going to be super important to look out for. And now let's cover Neisseria. Okay, so for Neisseria, is it gram positive or gram negative? That's the first thing to know. It's gram negative. If you see the sketchies, it's gram negative. It presents with cervicitis and also pelvic inflammatory disease as well. Pelvic inflammatory disease is associated both with chlamydia and also Neisseria, the US. All right. Yeah. And I think that is the most high yield information there. And Lula says, yes, negative. Nailed it. 100%. A 34-year-old male visits his primary care physician with complaints of a sore throat, white patches on his tongue, and a burning sensation on the mouth. He recently completed a 10-day course of amoxicillin. He denies any fever. On physical examination, there are extensive white plaques, and they're scraping off easily. What is this? This is super buzzy for our condition. We should know this now. Candida. Yep, this is Candida. All right. So here are the trap answers. Epstein-Barr virus, that's hairy leukoplakia, and there they are not scraped off easily and often on the lateral tongue. Group A strep, exudative tonsillitis. Coxsackie has vesicular on the hand, foot, and the mouth. Lesions are ulcers, not white plaques. Herpes simplex virus, painful vesicles and arithmetic base. They're not removable plaques. So this is an opportunistic fungal infection. Whenever the normal flora is disrupted, in this case with amoxicillin, it wipes out the bacterial flora in the mouth, and it gives Candida a chance to grow, and it can be scraped off. That's pretty much all we need to know about this. We use a broad spectrum antibiotic, and also it's affected by immunosuppression, so HIV and AIDS, and elevated glucose would help. So if you have diabetes, immunosuppressed, or inhaled corticosteroids, you're suppressing these kind of local immunity, or you're allowing furtive conditions for fungal growth, or you're decreasing the oral clearance of fungal colonization with your denture wearing and your neonates. All these things can cause the opportunistic infection syndrome to grow. So the answer is indeed C, and Lula got it right. Scrapable plaques. Scrapable plaques is what you should be thinking of here. All right, and so we finished amoxicillin. We have a sore mouth, we have patches on the tongue, and we have a burning sensation. And you scrape out those plaques, and they have a red, irritated base. So he's not febrile, he has no cough and no exudative tonsillitis, and so it's not strep or mono. This is antibiotic use, and it's wiped out the normal flora, and that gives Candida a chance to grow. All right, so pseudomembranous candidiasis or oral thrush is the answer to this question. Here's the bottom line, my friends. Candida albicans causes oral thrush characterized by white plaques that scrape off, especially after antibiotic use.
These creamy, easily scraped off plaques, along with a burning feeling in the mouth after a recent course of antibiotics, are classic for oral thrush or candidiasis.
All right, so let's check out these drainage patterns here. There are way too many holes in the human head. That's something I've learned in medical school. So sphenoethmoidal recess, right here, superior nasal meatus, and here's the semilunar hiatus. Here's the middle nasal meatus, the inferior nasal meatus, and here's your opening of your lacrimal duct, and there's the opening of the eustachian tube. Okay, so sphenoethmoidal on the top, superior, and then we have our semilunar hiatus, and then our middle nasal meatus, and then our inferior, and then here's the opening of the nasolacrimal duct, and here's the opening of the eustachian tube. Here's another look. We have our middle turbinate, inferior turbinate, our nasal cavity, and our superior. So superior, middle, inferior. That's easy to remember because of how they're located. And our frontal sinus is at the very, very top. There's the semilunar hiatus right there, middle meatus, inferior, and superior. Let's look at some more diagrams here. Here's the frontal sinus. There's the opening of the maxillary sinus. Here's the maxillary sinus itself, the middle concha right here. And then here's our inferior meatus and inferior concha right there. This is what it looks. Frontal sinus, ethmoid, nasal cavity, maxillary sinus. Okay, so this is going to be a really good one for our question at hand here. All right, so you guys can feel free to vote in the chat by doing !A, B, C, D, E in Twitch. So a 35-year-old man presents to the clinic. They have a 2-month history of facial pain, nasal congestion, and purulent nasal discharge. He has been treated twice with antibiotics, but has shown no improvement. On examination, you note tenderness over the right cheek and decreased translumination of the right maxillary sinus. A CT scan confirms chronic sinusitis of the right maxillary sinus. The decision is made to perform a surgical procedure to directly drain the affected sinus. Which of the following anatomical locations should be targeted to effectively drain the right maxillary sinus? So here's our maxillary sinus right here. There's our maxillary sinus again. So on somebody's face, we're looking at this big old sinus right below their eye, pretty much. No, 20 push-ups. All right, sounds good. We'll do 20 push-ups in a second, okay? Dr. Mui says M is for maxilla, M for the middle. Very nice. Maxillary sinus right here. Excess mucus. In a sinus infection, you have that excess mucus right here. You have a sinus infection. Here's the frontal sinus. You have inflamed sinus lining. So this is in sinusitis, so you can kind of see the difference. Your sphenoid, your ethmoid, frontal. This is actually the best photo I've seen in a long time. So frontal, sphenoid, ethmoid, and then your septum right here. People talk about a deviated septum, and also your maxillary sinus. Okay, so frontal, sphenoid, ethmoid, then your septum and your maxillary sinus. Okay, and they get excess mucus and sinusitis. That's where it's also located. I just think it's so important to look at just tons of photos because you guys are going to be working with actual patients. You're not going to be working with images, right? They're not going to show up and be like, hey, look at this image of my sinus. They're going to present as a human being, okay? So healthy, inflamed, obstructed, fluid, ethmoid, nasal, maxillary. Now, let's do this question together. Okay, so looking at the chat here, I can see there are some votes, and B is what we're thinking for middle meatus, and that's indeed going to be correct. And we'll talk about why some other answers are incorrect. So persistent facial pain, nasal congestion, purulent nasal discharge, lasts more than 12 weeks, it's going to be chronic sinusitis. Yeah, it looks painful indeed. Tenderness over the right cheek, All that tells us is maxillary sinus involvement. Cool. And so we know that's what's involving. And now we just have to know the drainage pathway. And as Dr. Mui has pointed out, maxillary sinus drains into the middle meatus via the semilunar hiatus. Okay, so that's how they're going to ask you this question. Semilunar hiatus right there. That's going to be the draining point. And where is it going to go? Into the middle meatus. Okay, so maxillary sinus drains into the middle meatus for effective treatment of chronic sinusitis. That's the bottom line. Okay, so you can see all these other answers. Superior, only the posterior ethmoid drains there. Inferior would be the nasolacrimal duct. The tear duct goes into the inferior, and the posterior ethmoid goes into the superior. The sphenoethmoidal recess is the drainage site for the sphenoid sinus, and the nasolacrimal drains into the inferior. Okay, so nasolacrimal inferior, maxillary is going to be the medial, and superior meatus has the posterior ethmoid involvement. Very, very good stuff. All right, time to move on to our next question. I'm going to do some push-ups that I owe Chest Noob for reimbursing her channel points to do some push-ups. All right, 20, here we go. 20. All right. Oh, Spanish mode. So here we go. 13-year-old girl is evaluated for persistent sweating and pain in her left thigh that's been gradually worsening over the past month. She mentions increasing difficulty bearing weight on her affected leg. Physical examination has tenderness and palpable mass of the distal thigh region, and lab studies are showing elevated alkaline phosphatase levels, and an MRI of the thigh indicates destructive lesion of the distal femur with periosteal elevation and soft extension. The lesion displays a characteristic sunburst pattern. Okay, and a biopsy is showing spindle-shaped cells. Okay, so we're thinking B on this one, or we're thinking A. So there's a 13-year-old girl. She has swelling and pain in her distal thigh. That's going to be an osteosarcoma. So first of all, we have to know that the diagnosis is osteosarcoma. That helps us with everything else, right? So a couple of things are pointing us to the osteosarcoma. One of them is the age and also the distal femur, the location. They also tell us there's a sunburst pattern on the x-ray. So that's in periosteal elevation. That's also known as Codman's triangle. Codman's triangle on x-ray. And so these are classic radiologic signs here. I know it's on long bones between B and A. Nice. Very, very good place to be. So elevated alkaline phosphatase has increased bone turnover. So she has that. And osteoid production in atypical cells is a hallmark of osteosarcoma. So we know this is osteosarcoma. That's the first step, okay? And then osteosarcoma is a bone tumor that's seen in adolescence, and it's commonly affecting the rapidly growing metaphyseal regions of the long bones, especially around the distal femur and the proximal tibia and the proximal humerus. And so the humerus is typically a secondary site. And so that's definitely going to be a good answer. So it's going to be humerus. The patella, that's a rare location for the primary bone tumors. And it's wrong because it's not a metaphyseal site. And it's rarely going to be involved in osteosarcoma. All right. The calcaneus, that is more associated with Ewing sarcoma or metastasis. The ilium is a common site for Ewing sarcoma and metastasis as well. And the scapula, that is a flat bone, not a metaphyseal site. And so it's not common for osteosarcoma. All right. So that's the rundown there. And one thing that's worth mentioning is the metaphysis. This is the flared portion of the long bone between the diaphysis, which is the staff of the bone, the diaphysis, and the epiphysis, which is the head of the bone. And so it's super vascular and metabolically active, and it makes it a prime target for tumors and infections and growing bones. So those metaphyseal regions, that's what you should be thinking about. The distal femur is the number one site of us in adolescents with knee pain. The proximal tibia is going to be involved in osteosarcoma and osteomyelitis. So there you think like, okay, below the knee, part of around the knee sites, that's going to be where the proximal tibia, and that one you should think of like osteosarcoma and osteomyelitis as well. So yeah, your tibia, of course, is going to be below your knees, or like around your knees. The proximal humerus, that's another favorite site for osteosarcoma. That's going to be shoulder pain in a young athlete. So just for osteosarcoma, think about like the distal femur, proximal tibia, proximal humerus is another site. Maybe even the proximal femur as well is a good site for that. All right, so femur, growth plate, shoulder, humerus, cancer. Here we go. There's our bottom line. Sunburst pattern with elevated alkaline phosphatase in a young patient suggests osteosarcoma, commonly found in the distal femur and the humerus. Long bones, diaphysis, metaphyseal, epiphysis. Metaphyseal portions going to be growing, long bones. So the metaphysis, osteosarcoma, osteochondroma, aneurysmal bone cyst associations. All right, for our next question, let's talk about when different levels are increased. So if I were to tell you methylmalonate, homocysteine, and macrocytic anemia, what's going to be coming to mind here? What are you going to be thinking about? You have to know when they're elevated, when they're decreased, when they're diminished, how the neutrophils are they hypersegmented, what causes them. Lula's thinking B12, maybe some, you have to know like veganism as well, pernicious anemia. Sometimes you have a surgery, tapeworm infection. You have to know subacute combined degeneration, Yep, folate B12 deficiency. You're onto the right stuff. So here's our question 3, 2, 1. A 62-year-old woman presents to the clinic with progressive difficulty in walking and memory problems for the last 4 months. She reports a tingling sensation in her feet. She underwent gastric bypass surgery 2 years ago. On examination, she has decreased vibratory sensation in lower extremities. Lab tests show macrocytic anemia, which the following most likely supports the diagnosis. Yes, our Crohn's good. Okay, there's a question by Chest Noob. What is macrocytic? So macrocytic just means larger than normal red blood cells. It's a term that is used to describe blood tests and different types of anemia. A lot of medical students are going to know this, Chest Noob, but this is basically macrocytic, means that you have a mean corpuscular volume greater than 100, and a normal is between 80 and 100. We have a 62-year-old woman presenting to the clinic with progressive difficulty in walking and also memory problems. So there's a neurological sign which points us to B12 deficiency, which means there's going to be increased methylmalonate. And she also has some sort of a gastric bypass surgery 2 years ago. That is important because it disrupts the intrinsic factor and also B12 absorption. So when they say gastric bypass, that's what they're trying to get you to think of. So this is indeed the right answer is D. And also this difficulty in walking and the tingling and memory problems, that's going to be classic for subacute combined degeneration to B12 deficiency. And also macrocytic is going to definitely support B12. Okay, so B12 breakdown, neuropathy, macrocytosis is what makes us think of B12, causing neurologic symptoms, and methylmalonic acid builds up B12 deficiency, not in folate deficiency. That's the key distinguishing factor. M is going to be increased in B12. And also it's subacute combined degeneration. You have the paresthesias, memory loss, macrocytic anemia. And so methylmalonic acid accumulates. Increased homocysteine is seen in both of them. So homocysteine is not going to tell you which it is. Decreased methionine is produced from homocysteine with B12, but it's not going to be the most reliable indicator. Methylmalonic acid would be. And the systemic effects, the hematologic, the psychiatric, the neurologic, has very acute, subacute combined degeneration of the spinal cord, loss of proprioception vibration. So it's just a very classic presentation due to malabsorption. So that's why they like asking about this one. Here's the bottom line. Increased methylmalonic acid indicates vitamin B12 deficiency, likely due to malabsorption and a post-gastric bypass. All right, moving on to our next question. Let's say that we have somebody who is trying to see their risk for the BRCA gene. And they have many people in the family tree who have died. And this is the person we're talking about right here. It's a female. She's like, hey, do I have BRCA gene? This is her family tree. So her mom's sister has it and her mom's dad had it. Okay. So then we have to find the probability that you're inheriting it, that the patient has to inherit the mutation. And so this is also going to be transmitted through an autosomal dominant fashion. And so basically what's happening here is that the probability the patient inherits the gene from the mom is going to be 50%. So both of the genes are inherited in autosomal dominant fashion, but the status of the mom is 50%. And so that means the overall probability is going to be 25%. Yep. So the answer is C. You got it right. 100%. Because if we don't know the status, basically it's going to be it'll essentially be a 50-50. So it's going to be a 50-50 chance is that we know that this is a heterozygous individual because they've been genotyped, and then they're passing on a 50-50 chance that this person has it. And then there's also a 50-50 chance that this person has it. So it's 1/2 times 1/2 because it's 50-50 chance here, 50-50 chance there, multiplying by 2, it's 0.5 to the second power. And that gives you 0.25, which is our correct answer. So yes, it's autosomal dominant configuration. Hematopoiesis is right. Lula's right. Good job. Here's our bottom line. Moving on to our next one. So for this one, we're covering some topics about calories. We have a 32-year-old man decides to improve his fitness and lose weight. And he's 5'11" and he weighs 225, BMI is 31. He's reducing his intake to 1,800. He currently expends about 2,800 through usual routine. Assuming he strictly adheres to the plan, at what rate is he going to lose? Okay. So basically he's intaking 1,800 and he's expending 2,800. So he has 1,000 deficit of kcal per day. And then we know that 3,500 is going to be 1 pound of fat. And so that means that we have 1,000 times 7 divided by 3,500 because there's 7 days in a week. And so that's going to be 2 because it's 7,000 divided by 3,500. So he's going to be losing about 2 pounds each week. So really the conversion ratio is all you need to know there of pounds to calories. 3,500 for 1 pound. Here's the bottom line. Caloric deficit of 1,000 kcal per day leads to approximately 2 pounds of weight loss weekly. All right. And there's one other thing that's worth knowing on questions like this. What you should know about this one is that your carbs, 4 cal per G, protein, 4, your fat is 9, and alcohol is 7. Okay. So that fat stores it up, and then it's alcohol, and then it's the carbs, and also the protein are going to be the same amount. So 4, 7, 9. So yeah, fat is 9 because it's most dense. Alcohol, it gets you tipsy at 7, and carbs and protein are both 4. Alrighty. So Alcohol metabolism contributes to a lot of the empty calories that you have in your body. Okay, moving on to the next question. This is going to be an ethics question, kind of. But yeah, when you drink alcohol, your body metabolizes it in the liver, right? And there are two major steps that are involved in the liver. The first one is ethanol into what? Ethanol into acetaldehyde, and that's through alcohol dehydrogenase, ADH, ethanol into acetaldehyde. And there's a cofactor involved there, which is NAD plus, turns into NADH, and that's located in the cytosol. And then the next step is we have this acetaldehyde, and we turn that into acetate. That's through aldehyde dehydrogenase, and also you have a cofactor where you do NAD plus into NADH, and that's in the mitochondria. And then you have acetate turns into acetyl-CoA, and then acetyl-CoA enters into the TCA cycle, or it's stored as fat. So each gram of alcohol has 7 kcals, and that is more than the protein or the carbs, but it's also less than fat, but it's really nutrient poor. So it provides calories with no vitamins, minerals, or fibers, or anything like that. And so that's why they're called empty calories. Okay, so here's our next practice question. So feel free to put in the chat your answer, A, B, C, D, E. And soon I'm going to add a feature where if you guys get the answer correct, then you get more channel points. So here's a 68-year-old man with a history of advanced heart failure and multiple hospitalizations for volume overload. Presents to the clinic with routine follow-up. He has difficulty walking short distances without stopping to catch his breath. Medications include carvedilol, lisinopril, and his current vital signs include a blood pressure of 110/70, heart rate of 88, and respiratory rate of 22. When asked about his goals for the future, he expressed concerns about dying in the hospital and prolonging suffering. Which of the following is the best appropriate initial approach for the physician to explore the preferences for end-of-life care? Okay, so a lot of these ethics problems just are surrounding just like basic kind of listening here. Basically, you got to listen more. You can't move on to talk about DNR orders. You should just say, hey, can you tell me more about why this is important, right? Open-ended stuff, and let's look at these other answers. If your heart fails, ask about the values first. He's concerned about dying in the hospital, emotional readiness, and he has a high morbidity, so you got to talk with him about it, but you got to make sure you get their values first. All right, 52, recently divorced man, visits for a regular checkup, and this is just asking about safe sex practices and always use a condom. So condom use is essential for safe practices and STI prevention. Lubricant doesn't help. It's not preventative, that is. And everything else is kind of ridiculous. So that was a really easy question. Okay, use condoms. So here's our next question. We have a 52-year-old woman presents to the clinic with a 3-month history of climbing stairs, difficulty, and also the dryness of the eyes and mouth. She reports occasional urinary retention and lightheadedness when standing up quickly. She has a history of chronic obstructive pulmonary disease and has been smoking 2 packs of cigarettes daily for 32 years. An examination has proximal muscle weakness with diminished tendon reflexes. And she has some antibodies against the voltage-gated calcium channels. And there's also highlighted mass. What is the mechanism? Yep, you're correct. This is a Lambert-Eaton. Oh, wait, you said Lambert-Eaton syndrome, right? And you picked A as your answer, and A is going to be postsynaptic, right? So that's myasthenia gravis stuff. The answer is the increased impaired release of neurotransmitters into the synapse. So it's C. So Lambert-Eaton syndrome is going to be the voltage gated at the neuromuscular junction. There's no calcium for it to be released. So postsynaptic would be myasthenia gravis. Polymyositis would be autoimmune destruction of the muscle fibers, increased breakdown of peripheral acetylcholine, cholinesterase, inhibition of CNS acetylcholine synthesis in Alzheimer's disease. That's a cholinergic loss of cognitive function. Also that Hyler stuff, the small lung cell carcinoma, is going to be associated there. All right. So your immune system is targeting your own nerves. That's what's happening in Lambert-Eaton syndrome. It's a paraneoplastic condition triggered by small cell lung cancer. If I tell you finger-like, what does that make you think of? Finger-like projections? Yeah, good. And unfortunately here we're going to actually see the answer. We have a 5-month-old female infant brought to the pediatric clinic by her parents due to hoarseness, and they have some stridor and multiple wart-like pedunculated lesions on the larynx. These findings are most consistent with which infection during pregnancy? The answer is human papillomavirus. So it's the inspiratory stridor is going to show you there's an extrathoracic airway obstruction. The wart-like stuff is really what's going to tell you that it's papillomatosis, and it's caused by HPV 6 and 11. HPV 6 and 11. So the infant has respiratory papillomatosis caused by 6 and 11, and it's acquired during the passage through the birth canal. And you have that finger-like projections on HPV. Yeah, nice, Lula. Inspiratory stridor, wart-like pedunculated lesions, papillomas, they're squamous growths. So yeah, the baby's first breath can be obstructed by warts. And this isn't a torch like CMV or toxo. This is just HPV. It's an infection. Here's the bottom line. Neuromuscular symptoms in the patient are due to impaired neurotransmitter release from antibodies against voltage. That's the one from the last question. So for this one, basically what I would say is anytime you have wart-like pedunculated lesions in the larynx, you should think of laryngeal papillomatosis. And that persistent hoarseness and stuff, that's going to be an airway obstruction. And also just know that this is during vaginal delivery of HPV. So there you have it, folks. For this one, we need to explain all of these conditions. Okay, hematopoiesis is really good at those blood questions. So you are indeed correct. Hematopoiesis, the answer is C, binding platelets to the exposed collagen. So it's the frequent nosebleeds. 23-year-old female presenting to primary care because of the frequent nosebleeds and prolonged bleeding, minor cuts. And she's had this since childhood. She's got petechia on her arms and legs, but no ecchymosis. And she has normal platelet and normal PT and prolongation of bleeding time. So the bleeding time is what's elevated. So there's a defect in what? Von Willebrand's factor. All right. Very nice. I'm glad you guys are using that feature. And soon it'll give you guys channel points. Scatterpetechia, that's going to be platelet related. So petechia is the hallmark of platelet disorders. So, there's a platelet involved. But they have a normal count and normal PT, but a prolonged bleeding time. And that is what tells you that it's von Willebrand's. And there's a defect in the synthesis of blood protein critical for adhesion. It's an adhesive protein. It's essential for the adhesion via GP1B. Adhesion. All right. Activation of fibrinogen cascade, part of secondary hematopoiesis, segregation of the platelets through ADP release would be GP2B. So let's talk about all of these. Activation of fibrinogen. So fibrinogen activation, secondary, not adhesion. GP1B 3A, that's platelet to platelet aggregation through ADP release. Conversion of fibrinogen to fibrin, that's going to be involved in thrombin activity. Oh boy, push-up time. So that's downstream production of prostacyclin. Would be involved in vasodilation. So I'll do some push-ups right after this one. So autosomal dominant is the most common type. PTT in some cases, von Willebrand factor stabilizes, and you get desmopressin treatment, and you're stimulating that von Willebrand factor release from the endothelial cells. I'll make the next question ready to go while I do the push-ups. All right, here's the next question, guys. Question 37. A 55-year-old man with a history of cirrhosis secondary to chronic hepatitis C is admitted to the hospital with confusion, lethargy, and strixus. His lab studies reveal elevated serum ammonia levels. The patient is started on lactulose therapy, which improves his mental status. The attending physician explains to the patient that liver dysfunction has led to an accumulation of ammonia in his blood. Which of the following processes is most compromised in the patient's liver, contributing to the hyperammonia? All right, so be sure to use exclamation mark A, B, C, D, E, and we'll see if that works to vote on what the correct answer is. Okay, so we have a 55-year-old man. He's confused, he's gastric, and he has all these signs of hepatic encephalopathy, as Dr. Moise has pointed out. And so his ammonia is high. Lactulose helps by trapping ammonia in the gut. That's why they give him lactulose therapy, because his ammonia is high. And so because his liver can't make urea anymore, normally the ammonia is converted into urea by the hepatocytes, and then it's excreted in the urine. But in cirrhosis, the urea cycle, it breaks down, and the ammonia is leaked into the blood and the brain. But the liver's not making any urea, right? And so that ammonia, basically the urea cycle is broken down, and ammonia is going to leak into the blood and the brain because you can't make it into urea. And so our correct answer is indeed going to be D. And we'll do 20 more push-ups after this one. So cirrhosis is secondary to hep C. You have confusion and asterisk, elevated serum ammonia. It's just failure to detoxify nitrogenous waste, improves lactulose, liver dysfunction, leading to cycle failure. Ammonia buildup. Hepatic encephalopathy arises when ammonia crosses the blood-brain barrier and disrupts astrocyte function. Liver cirrhosis impairs, leading to toxic nitrogen accumulation. So beta oxidation of fatty acids. That's wrong because it's mitochondrial, not ammonia. Conversion of cholesterol to bile. That's involved in fat solubility, gluconeogenesis, hypoglycemia during fasting, protein synthesis, hypoalbuminemia, and coagulopathy. And so to detoxify nitrogen, we have to do the urea cycle. And so we use lactulose or rifaximin, because the liver can't make any urea. So here's the bottom line. Hyperammonia and cirrhosis results from compromised urea synthesis due to a liver dysfunction. All right, time to do 20 push-ups, and we'll go on to the next one. All right, so here we go. A 45-year-old man with a history of alcohol use disorder presents in the clinic with confusion asterixis. We kind of already touched on this one before. It's just the formation of urea from ammonia is our correct answer. So in cirrhosis, we lose the ability to clear ammonia through urea. Astrocyte buffering is involving glutamate to glutamine in the brain. Glutamate to glutamine. Synthesis of glucose from lactate is the chorea cycle. Production of ketone, a starvation state, and glycogen to glucoses, and hypoglycemia is not the issue here. So yeah, your brain is getting poisoned by your gut again. How fun is that? So let's do our next question. Here's our next question. All right, so we got an ethics question here, and always on these, I like to have like the guiding principles, because you should always start with the principle in mind and then switch from there. Explain the significance and discuss the implications. You can't lie to them, say it's negligible. You can't just reassure their actual concerns if it's not worthy of reassurance. And a lot of them are common sense indeed. Waiting and see, no, you have to attenuate to the actual concern. And some of these just aren't going to be helpful. Like getting genetic counseling is recommended. So trisomy 21. So you could do some sort of a chromosomal analysis test. And if one parent carries a balanced translocation involving chromosome 21, they're phenotypically normal, but increased risk of having a child as well with an unbalanced chromosomal content. Okay, 45-year-old woman presents to dermatologist with concerns about thinning hair. She mentioned similar hair loss was observed in her mother and older sister. Physical examination reveals diffuse thinning over the top of the scalp and frontal hairline with preservation of the occipital scalp. What is the most likely mechanism of her condition? So it is indeed DHT binding to androgen receptors. Thinning hair, this is like non-scarring alopecia. And so this is going to be alopecia. Androgen causes this. So just androgenic alopecia. Increased estrogen, that's protective against the hair. Decreased thyroid hormone production, maybe brittle. Hypothyroidism causes the hair thinning, but not the pattern of loss that we have. Excess cortisol secretion and Cushing syndrome. Says, what are the implications of this and polycystic ovarian syndrome? That's a good question. So basically, polycystic ovarian syndrome is going to be a hyperandrogenetic state. So basically, the ovaries and also the adrenals are secreting excess androgens, especially testosterone. And then this excess testosterone is converted into DHT by 5-alpha reductase, and that drives androgenic hair loss. And that's caused by DHT binding to the scalp hair follicles. And then also hirsutism is seen with PCOH. That's the hair growth in the male distribution. So like the chin, chest, the back, the abdomen. That's also due to DHT, but it's on different follicle populations. And then, so that's hirsutism. And then also acne. So androgens are going to produce the sebaceous gland activity. So polycystic ovarian syndrome, for step one, you should think of anovulation, insulin resistance. And the treatments for that are going to be suppressing the ovarian androgen production with OCPs. And also you're blocking the DHT effects with spironolactone. That's why a lot of women are on spironolactone. And you have insulin sensitization as well. So metformin, something like that is what you use here for PCOS. But so there is a little bit of carryover there for sure through the androgens. And then you also ask a question about CAH disorders in 21. So yeah, 21 hydroxylase deficiency, that's the most common, right? And that's an enzyme block of 21 hydroxylase. And so you need that to have cortisol and aldosterone. So the pathology is you have less cortisol and then more ACTH because of the negative feedback. And ACTH stimulates the adrenal hyperplasia, and that causes the production of adrenal androgens. And then the pathway is shunted toward androgen synthesis. So you have increased DHEA, and then that causes androstenedione and testosterone as well. And then in children, you can have some advanced bone age and early pubarchy. And then in adolescence, you have hirsutism, acne, androgenic alopecia, and also menstrual irregularity. So 21-alpha hydroxylase, the elevated adrenal androgens and DHT can lead to the same kind of pattern of hirsutism, acne, clitoromegaly, that kind of stuff as well. Dendritic hypertrophy. So it's the exact same thing here. It's just a little bit different because it's a 60-year-old woman and left ventricular hypertrophy here. So really good. On to our next question. 8 questions left. Okay, here we have a 22-year-old medical student brought to the emergency department by the roommate after ingesting a substance at a party. The student is disconnected from the surroundings and has vivid visual hallucinations. They report feeling out of the body, and we have normal vital signs demonstrating significant nystagmus. And they took a research chemical sold online saying that it has effects similar to a dissociative anesthetic. Which of the following does the student likely experience most closely resemble? All right, this is a good one. So they have an out-of-body experience, they're disassociating, and they also have nystagmus. All that leads us to think that it's some sort of a dissociative thing with an anesthetic. Yeah, it's a dissociative anesthetic. And so they're probably getting at some sort of a PCP analog or ketamine. And you have nystagmus and hallucinations and disconnection. That's going to be ketamine or PCP toxidrome. And so normal vitals and slurred speech are going to favor ketamine over stimulants or opioids. And so the answer is going to be ketamine. Disassociation from surroundings, out of body is classic with NMDA antagonisms. Antagonists like ketamine. Vivid visual, that could be shared with LSD, but combined with disassociation, it's going to be more toward a dissociative hallucinogen, not a serotonergic hallucinogen. Significant nystagmus, it's going to be associated with PCP and ketamine, not LSD. So it's the nystagmus that gets you. Research chemical, ketamine analogs. So dissociative problems. So visual hallucinations, dissociation, NMDA, ketamine-like toxicity. Ketamine is dissociative anesthetic that blocks NMDA receptors, detachment from body, sedation, nystagmus. LSD has visual hallucinations. Heroin, respiratory depression, pinpoint pupils, normal vitals. Heroin is a mu-opioid agonist causing sedation, not hallucinations or dissociation. Cocaine, sympathetic increased heart rate would be seen. Diazepam is used for its anxiolysis and sedation. So classic hallucinogens, serotonin, 5-HT2A agonism, and dissociative anesthetic would be PCP and ketamine because they're NMDA antagonists. Deliriants cause confused and agitated and dry states. Ketamine infusions are all the rage these days. But yeah, often amnestic as well. So basically causing memory loss or anterograde amnesia, the inability to form new memories. And that's just not going to be relevant here. Timothy O'Leary invented LSD. So vivid hallucinations in nystagmus and young adults suggest dissociative effects, most likely from ketamine or similar substances. All right, on to our next question. 52-year-old man presents to primary care physician for evaluation of persistent hematuria. He has recorded noticed blood and urine, and admittedly the past month he denies any pain during urination, fever, or recent infections. His medical history is significant for smoking 1 pack of cigs for 25 years. BMI 28, normocytic anemia and elevated calcium. Abdominal ultrasound shows a solid mass in the upper pole of the right kidney. Solid mass, upper pole of the right kidney. Nephrectomy is performed, and histopathological examination reveals cells with abundant clear cytoplasm, which of the following is most likely the diagnosis. And hematopoiesis says C, that is indeed the correct answer. It's going to be renal cell carcinoma. Angiomyolipoma would be a fat-containing benign tumor seen in tuberous sclerosis, not smoking. Wilms would be under 5. This patient's 52. Oncocytoma is eosinophilic cytoplasm, not clear cells. And lymphoma would be diffuse enlargement or mass. And then also B symptoms, does not produce clear cells. So renal tumors, renal cell carcinoma, arises from the proximal convoluted tubule and goes undetected until advanced subtle signs like hematuria and paraneoplastic syndromes like hypercalcemia, polycythemia. Histology has the clear cytoplasm. It's due to the high lipid and glycogen content and clear renal cell carcinoma. Smoking, carcinogens damage the renal tubule epithelium. Von Hippel-Lindau, inherited cause of RCC. Loss of VHL tumor suppressor gene increases HIF and increases VEGF and angiogenesis. Polycythemia due to ectopic EPO, paraneoplastic syndromes, hypercalcemia, and all that good stuff. So labs, we have hypercalcemia, anemia, and possible increased EPO. So this can cause hypercalcemia without any bone problems, which points you to renal cell carcinoma. So ketamine blocks NMDA receptors, which are glutamate-gated ion channels for our last question. Glutamate is important for that. And for this one, we think of the hematuria, the smoking history, the solid renal cell mass, and also the renal cell carcinoma. So the cells with clear cytoplasm is the hallmark for renal cell. It's a subtype of clear cell carcinoma, which is a subtype of renal cell carcinoma. And normocytic and hypercalcemia is going to be suggesting that it's renal cell carcinoma with a paraneoplastic syndrome. And the upper pole mass is the classification because of the renal tubular epithelial origin there. So renal cell carcinoma originates from the proximal renal tubule epithelial cells, strongly associated with smoking, obesity, sporadic VHL gene mutations. So the painless hematuria, the blood in the urine, the smoking history, hypercalcemia, the mass, all that stuff leads you to believe that there's renal cell carcinoma. And that's because the tumor is secreting the paraneoplastic factors like parathyroid hormone-related protein, and that causes the hypercalcemia, and also EPO, polycythemia, and also IL-6 with the anemia of chronic disease. All right, persistent hematuria, smoking history, and clear cells says that it's renal cell carcinoma. Nice. All right, on to the next one, question 44. All right, here's the next question. We have a 72-year-old woman, history of hypertension and hyperlipidemia, comes to the clinic with mild epigastric comfort and also fatigue. She denies any nausea or vomiting. Vital signs show blood pressure of 145/90 and a pulse of 95. An abdominal ultrasound reveals a prominent but non-tender pulsatile mass in the midline, suggestive of an abdominal aortic aneurysm. Subsequent CT angiography demonstrates the aneurysm to be infrarenal with evidence of mural thrombus and extension of the major branch artery. Compression of this vessel would most likely show the blood supply of which of the following organs? A surgeon question. That's funny. Let's break down this first part, like history of hypertension and hyperlipidemia. What is that? What should you be thinking about when you're taking this silly test, right? Hypertension and hyperlipidemia. And let's say that she has some epigastric discomfort as well. And abdominal ultrasound that has a pulsatile midline mass, that's going to be an abdominal aortic aneurysm, a AAA. And so CT shows the aneurysm is infrarenal. But these two risk factors, hypertension and hyperlipidemia, that should make you think of atherosclerosis. So when you're answering this question, you should say, okay, old person and atherosclerotic risk factors. That's like how you should decode this in your mind. And so this should lead to menu differential. Already you're thinking cardiac, right? Coronary artery disease, angina, myocardial infarction, diastolic heart failure, S4 gallop, right? Left ventricular hypertrophy, aortic stenosis, pressure overload, right? That's what you're already thinking just by reading this first sentence. Or you could be thinking, okay, am I going to see some neurovascular signs like ischemic strokes or vascular dementia or intercerebral hemorrhaging if there's uncontrolled hypertension? Or you could say, okay, is there going to be a dissection like a AAA, especially in older patients, right? Aortic dissection, more in men, but it's still a risk. Peripheral vascular disease, claudication. Renally, I could see hypertensive nephrosclerosis. I could see renal artery stenosis and secondary hypertension, right? So all these things should be coming to mind by the sheer fact there's hypertension, hyperlipidemia, and age above 65. So you should assume atherosclerosis. That's like your assumption. If there's abdominal or back pain, then you should be thinking of a AAA or some sort of a dissection. If there's a neurologic change, stroke or vascular dementia. If there's chest pain, coronary artery disease, dissection, or aortic stenosis. If there's epigastric pain, then you could think of mesenteric ischemia. And if the labs show creatinine rise, then it's going to be renal artery stenosis. So already you should kind of like funneling yourself down these flow charts in your mind. So the vessel would most likely affect which of the following? Well, look at this, epigastric discomfort. So which blood vessel is this going to be affecting? Epigastric discomfort, what would we say? So the only branch that supplies a vital organ near that level is going to be the superior mesenteric artery because it's infrarenal. And so you have compression or thrombosis would affect the small intestinal blood flow, and that's from the superior mesenteric artery, and that leads to the ischemia. So the answer is going to be the small intestine. Hopefully that explanation made sense. Prominent non-tender pulsatile mass in the midline. So we have an abdominal aortic aneurysm. There's an infrarenal location, ding, 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 most common site for a AAA, and lies below the renal arteries. And then we have an extension into a major branch artery. Well, that is buzzy for a superior mesenteric because we have involvement of a visceral branch of the abdominal aorta. There's compression of the vessel, and that tells us that we're dealing with something to the small intestine. Okay, let's look at these other answers. The spleen, the clean machine. That's also going to be the celiac trunk territory through the splenic artery and arises above the level of the infrarenal aneurysm. Above the level. Bladder, superior, inferior vesicles. So for the spleen, though, aortic dissection can be involved with this because the celiac trunk is going to be the first branch of the descending aorta, and it'll supply the liver, the stomach, the proximal duodenum, the pancreas, and the inferior esophagus, and also the spleen. So you have dissection there, and the spleen could definitely be a worthy spot to consider. Midgut versus foregut. So the foregut, celiac trunk, midgut, which is involved in this particular question, is the SMA, and then hindgut is the IMA. So the SMA rises just below the renal arteries, making it vulnerable here. SMA syndrome, compression of the third part of the duodenum between the SMA and the aorta. Luisa says epigastric pain in an old lady and hypertension, hyperlipidemia. You said TBH, that reminds me of chronic mesenteric ischemia. Yeah, I think that makes sense because you have postprandial epigastric pain, like intestinal angina, food aversion, weight loss, vascular disease is what you'd probably be seeing with chronic mesenteric ischemia. And so definitely, I think you're right. But the reason why it's not that in this case is there's no mention of the postprandial worsening or the weight loss. For mesenteric ischemia, you'd probably be thinking of a little bit more of the postprandial, like after you eat, it gets worse. And also the CT shows an aneurysm, not a mural thrombus, right? So that's a distinguishing factor there in metapoiesis. Physical exam also has that pulsatile mass, right? So that's the AAA, not necessarily mesenteric ischemia. AAA is more likely because of the pulsatile nature. But you're right. There's definitely a lot to go on there, which leads you in that direction. So that's definitely a good diagnosis of that. But if it's dilation, then you should think of AAA. Pulsatile mass was a distinguishing factor. Yeah, for sure. Okay, here's the bottom line. Compression of the inferior mesenteric artery affects blood supply to the small intestine. Yeah, I hear what you're saying in metapoiesis, and that's totally right to think of. If no pulsatile mass, definitely good to think about the narrowing of the arteries and mesenteric ischemia, especially if there's a mural thrombus. All right, you're going to see the answer on this one, but just bear with me. This is a hard question only for the reason that they don't describe it as the way you'd think. And honestly, it's kind of unfair because they're always going to say this is a click. It's a click sound. What's the source of that clicking noise? It's a pipe bomb. Hooray. That's the Harry Potter puppet show. But yeah, you get the idea here. We have palpitations, we have dizziness, and his father had early valve surgery. And on auscultation, you hear a sharp click over the S1 and a late systolic murmur over the apex. Just be aware that they can describe this in many ways. We have a high-pitched click sound after the S1 heart sound and a late systolic murmur best of the cardiac apex. So it's a mitral valve prolapse. Mid-systolic click, mitral valve prolapse. The late systolic murmur best heard at the apex is an MVP with the valve leaflets that fail to coapt fully. So it's just the floppy mitral valve leaflets that bulge into the left atrium during systole. So whoop, and that click is from the tensing of the chordae, and the murmur is from the mild mitral regurgitation. And those palpitations, that's a palpitation, by the way, is the subjective awareness of your own heartbeat. So you have like the racing heart, the fluttering, pounding in the chest, right? It doesn't always mean that there's arrhythmia, but it's probably some sort of a weird cardiac thing because like you're not supposed to be super aware of that. And mitral valve prolapse, or people who have Marfan or Ehlers-Danlos, you have palpitations due to, well, a lot of things, maybe atrial arrhythmias. And you'll have like a mid-systolic click, late systolic murmur. Also, this could be seen with like palpitations could happen with hyperthyroidism, where we have increased beta-adrenergic sensitivity. So you have like tachycardia, afibrillation, palpitations, things like that. So it's not necessarily just an MVP for palpitations. It could be hyperthyroidism. And there you would check the T4, T3, and also the TSH. For anemia, you would be thinking of less oxygen delivery, right? So there's more compensatory cardiac output. So even anemia can cause a bounding pulse. Palpitations could also be caused by just general arrhythmias like supraventricular arrhythmias, atrial fibrillation, a whole bunch of things. Irregular rhythms, right? Panic attacks as well. You have an autonomic surge that causes your tachycardia and also your palpitations. But MVP can definitely be a cause of your palpitations because of the atrial and ventricular ectopy. And it's detected in routine auscultation of young adults. So definitely be listening to the stethoscope. So it's also worth mentioning what the autonomic surge is. So that's going to be if you have an abrupt, intense activation of the sympathetic nervous system, like a fight or flight response. So epinephrine, norepinephrine from the adrenal medulla, that leads to widespread adrenergic stimulation. And so you have increased heart rate, increased cardiac contractility, your beta cells, and also your vasoconstriction, so alpha 1, bronchodilation as well, rapid breathing through beta 2, pupil dilation as well, mydriasis is what that's called, GI slowdown, your beta and alpha, the nausea, the decreased appetite, the slowdown, and also you could have some increased glucose through the beta 2, so hyperglycemia or tremor. Here's the bottom line, folks. Mitral valve prolapse is characterized by a high-pitched sound after S1 and late systolic murmur at the apex. On to 46. All right, our votes are in. So a 45-year-old woman comes to the clinic because of a deepening voice and increased muscle bulk. Physical examination, she has acne on the face and hirsutism of the chest and abdomen. Blood pressure is 136, pulse rate is 75, testosterone is way up there, normal levels of DHEA, and a CT reveals encapsulated mass in the left ovary. What's the diagnosis? So let's break this question down, shall we? A 45-year-old woman has rapid onset virilization. All of a sudden she gets a deep voice. She's 45, right? She's a woman, has been for quite some time, according to her biological markers here. And also DHEAS is normal. So that means that it's coming from the adrenal glands. And so this is going to be an ovary sex cord stromal tissue. And so the answer is indeed D. It's not C. But I was looking at the image, and for a second, it looks like there are multiple cysts, but there's just one. There's one cyst here. So just to break this down, make this super, super clear. Polycystic ovarian syndrome would not cause as extreme hirsutism as you're seeing in this patient. It would cause some mild, like some moderate hirsutism, but you wouldn't see deep voice and muscle gain. So testosterone in polycystic ovarian syndrome is rarely, if ever, going to exceed 150. And also there's no solid mass necessarily. Thecoma, that's going to be sex cord stromal tumor, but it's estrogen producing, so we can cross that one off. A granulosa is going to secrete the estrogen, not the testosterone. So yes, you get double points for that one, hematopoiesis. Very nice. This one looks like polycystic ovarian syndrome until you realize actually that your testosterone is so crazy freaking high, and also there's deep voice and the muscle gain. These are kind of more testosterone heavy, and so it's actually just going to be a Sertoli-Leydig cell tumor, which is secreting testosterone. Granulosa cell tumor, that'd be precocious puberty and also bleeding. The deepening voice, the bulk, the acne, the hirsutism, all that stuff, that rules out polycystic ovarian syndrome a bit. Polycystic ovarian syndrome is a bit too mild because PCOS causes hyperandrogen, and that's hirsutism and acne and irregular menses, but it doesn't actually cause virilization. Virilization is the deep voice, increased muscle mass, clitoromegaly, that kind of stuff. 350 is way too high for PCOS, and also it's just going to be an ovarian mass instead of multiple masses. So this is actually a really good question. So just breaking this one down so that it's very clear in the end, what's happening is we have a 45-year-old woman, rapid onset virilization. She has a deep voice, which is virilization factor, and her testosterone is 350, so it's way above PCOS levels. And also DHEAS is normal. And that means that it's not coming from the adrenal glands. And so you have a solid ovarian mass, not tons of them. And so a solid mass more points you towards Sertoli-Leydig cell tumors. And these are going to be testosterone secreting, and that's why it's going to be extremely high. So really good question. Sertoli-Leydig cell tumor is the correct answer because of that testosterone being super high and also those virilizing factors. One thing I want to also mention is about like virilization versus hirsutism and why PCOS presents a little bit differently and like hyperandrogenism and virilization. So we'll talk about that in a second after we do our bottom line. Sertoli-Leydig cell tumor causes virilization in women presenting with elevated testosterone and an ovarian mass. So the virilization points toward the androgen secreting tumor. Okay, so the deep voice and the muscle mass, that's an adrenergic effect. And so you should think of adrenal or ovarian neoplasms for virilization. And so hirsutism has the terminal hair and androgen dependent areas like the upper lip, for instance, and also the chin and also the chest. Virilization is more extreme, basically. You have clitoromegaly, decreased breast size, that kind of stuff. And so PCOS causes hirsutism, but when you see virilization, you think of pathological androgen excess. All right, 3 more questions, then we're gonna take a quick break of just like 5 minutes or so and then dive right back in for more. Do we know metastases locations? Okay, we got our first vote in the chat, so we'll start this. 55-year-old woman presents to the clinic with a complaint of persistent swelling on the left side of her neck. She noticed this 2 months ago. She has a history of chronic alcohol use and reports occasional difficulty swallowing solid foods. Physical examination shows a firm, non-tender mass in the region of a jugular chain. And also we have a revealing ulcerative lesion on the left lateral wall of the nasopharynx. Histopathology confirms squamous cell carcinoma. The cancer has metastasized to which of the following nodes? Everybody's saying A in the chat. Very, very, very good job, guys. Yep. Nice. The cervical. So we have an ulcerative lesion on the lateral wall that's classic for nasopharyngeal carcinoma. We have a firm, non-tender neck mass in the jugular chain, so it's spreading to the cervical nodes. Alcohol use and dysphagia help clue you to the head and neck squamous, and then metastasizes to the upper, deep cervical lymph nodes via the lymphatic drainage. Nasopharyngeal carcinoma is associated with EBV, smoking, and alcohol use. Tends to metastasize early to cervical lymph nodes because of the rich lymphatic draining from the nasopharynx. So it's nasopharyngeal squamous cell spreading through the lymphatics, not the blood. That's important. Squamous cell carcinoma going through the lymphatics, not the blood. Lymph drainage from the nasopharynx follows retropharyngeal nodes to the deep cervical nodes, especially your upper deep cervical chain. Okay, axillary drains the upper limb. So we got to hit all these real quick. Axillary drains your upper limb and also your lateral breast, and it's not connected to the head and the neck drainage. Inguinal, that's the lower limb. Occipital is the posterior scalp, which makes sense. Retropharyngeal, they're not the palpable jugular chain swelling. They're secondary to the cervical nodes. All right, so we have some tobacco use, EBV. You have epithelial problems and that leads to a carcinoma, and invasive mucosa, and it goes through the lymphatic channels to the nasopharyngeal wall. Metastasis first occurs in retropharyngeal nodes in the deep cervical, and complications occur there. All right, so nasopharyngeal carcinoma can metastasize to the neck before it's detected in the nasopharynx. And so that's because the nasopharynx has like the richest lymphatic network in the whole entire body. And so she's got this left jugular chain that's going to key into the diagnosis. There's the answer to your question, thanks to our Ivy bot. So hematopoiesis does not actually have anything to do with vessel constriction. Hematopoiesis is the formation of blood cellular components in the bone marrow, and it produces red blood cells, white blood cells, and also platelets from hematopoietic stem cells, and that's driven by growth factors like EPO. There's the bottom line, squamous cell, the nasopharynx metastasizes to cervical lymph nodes. Coding all this stuff is like a full-time job. But the good news is we just got YouTube partnership today. Here's our next question. 57-year-old man, history of chronic hypertension and type 2 diabetes, visits the primary care physician with complaints of increasing exertional dyspnea and occasional palpitations over the past month. He reports no chest pain. He adheres to a regimen of lisinopril and metformin. Breast sounds have bilateral crackles at the bases. Lab studies show normal cardiac enzyme levels. What's the mechanism responsible for the patient's symptoms? All right, well, for this one, we have like 168 over 98. And so there's going to be some reduced compliance because it's a stiffened, non-compliant ventricle. And so the answer is going to be C for this one. Because they have chronic hypertension that causes concentric left ventricular hypertrophy. Concentric, because you can see the heart kind of being concentric, like with a C. It kind of looks like a C at the end of the day. And that S4 heart sound indicates the stiff ventricle and decreased compliance as well. And you have dyspnea, crackles, normal ejection fraction, diastolic heart failure, just remodeling of the heart. Hematopoiesis has a question, is reduced compliance the cause of hypertrophy? And shouldn't it be increased after load? Okay, so not necessarily, because reduced compliance is the result. It's not the cause here. So the correct causal sequence is we have chronic hypertension, and that causes increased afterload because it's hard to pump into that systemic pressure, right? And then we have left ventricular concentric hypertrophy, and that's because the muscle thickens to overcome that pressure, right? It's the afterload, which is increased by the chronic hypertension, and then that causes the thickening and the stiffness, and that decreases your compliance. So it's more stiff now. You have impaired diastolic filling as well, and you have increased left ventricular and diastolic pressure. And you have pulmonary congestion with an S4 and dyspnea, and so that's the lay of the land there. So yeah, it's increased afterload causes hypertrophy. And so the answer is reduced compliance. Another answer is, yeah, good, diastolic dysfunction. We have a 14-year-old girl brought to the emergency department by her parents because of a sudden onset of fever, altered mental status, and diffuse purpuric rash. Her medical history is unremarkable, and she is up to date with her vaccinations, except for the meningococcal vaccine. On examination, she is lethargic and has a temperature of 103.1. Blood pressure is low. Heart rate is 140 per minute. Respiratory rate is 28. And she is widespread petechia and purpura and white blood cell counts of 18, which is high. Hemoglobin of 9, which is low. Platelets of 50, which is very low. And elevated D-dimer levels. Blood cultures are obtained and a broad spectrum IV antibiotic is initiated despite aggressive fluid resuscitation. her blood pressure does not stabilize and she develops persistent hypotension. Which of the following is the most likely underlying complication contributing to her hemodynamic instability? Okay, some really good stuff I'm seeing in the chat. So basically we have a sudden fever and we have refractory hypertension, even though we're giving the fluids. And so this is some sort of an Addisonian crisis, right? Adrenal insufficiency. And there's unvaccinated in our clue as well. And so meningococcus is going to be also a susceptibility factor here. And this is fulminant meningococcemia that leads to Waterhouse-Friderichsen syndrome. So she's got a total adrenal crash, just like you guys have said. Very, very good. She's got Waterhouse-Friderichsen syndrome, and this is a complication of Neisseria. And so that's why our answer is C, bilateral adrenal gland hemorrhaging. So in Neisseria, septicemia, you have bilateral adrenal hemorrhaging, and that causes acute adrenal insufficiency, and you have a shock and unresponsive to fluid and vasopressors. So meningococcemia, persistent hypotension, even though you're giving vasopressors, is going to be because you have an adrenal crisis caused by a bilateral adrenal hemorrhage, which is Water-Friderichsen syndrome, and the hemorrhage is going to destroy the adrenal cortex, and that causes a big old drop in your cortisol and your aldosterone. And that causes a loss of vascular tone and sodium, so the shock continues, and you have hyponatremia, and also you have hyperkalemia. Hyponatremia, hyperkalemia. Because aldosterone would reverse that, right? How about acute renal failure? So that's possible in sepsis, but it's not the primary driver of unresponsive hypotension. Myocardial infarction, that's unlikely in a 14-year-old without cardiac history, so probably not. Severe dehydration. Dehydration can definitely worsen the hypotension, but she's already receiving fluids, and so no. Pulmonary hypotension, that's not acutely caused by meningococcus. So you wouldn't think of pulmonary hypertension. That would also show like a right heart strain, not a systemic collapse. Okay. Elevated D-dimer, all of that stuff. Disseminated intravascular coagulation. Acute renal failure would have oliguria and creatinine elevation. Myocardial infarction, chest pain, ST elevations, dry mucosa would be associated with severe dehydration, and also pulmonary hypertension has a loud P2. Last question, guys. You guys ready? Adrenal hemorrhaging. Last one, then we'll take a 5-minute break, and then we'll do the next little batch of questions. All right, let's dive into this one. A 56-year-old man presents to the clinic with a 3-month history of episodes of upper abdominal discomfort and bloating, primarily occurring after meals. He has a past medical history significant for obesity, has been attempting dietary changes to manage his weight. He denies any prior surgeries. Physical examination shows mild tenderness in the epigastric region without rebound guarding. Lab tests show normal liver enzymes. And also we have multiple gallstones without evidence. The patient expresses interest in non-surgical management for his condition. He describes a medication to reduce the cholesterol content of his bile, which is the primary mechanism of the medication. All right, so we have multiple gallstones without cholecystitis, and there's chronic, and so that suggests us that we have like some sort of a chronic cholelithiasis. And typically these are going to be cholesterol stones because he has a lot of gallstones without cholecystitis. And so there's non-surgical management that means we're probably going to be using like or similar meds because he doesn't want surgery. And we have to know what this does. We're reducing the cholesterol content of the bile. That is the key mechanism here. That's how we're dissolving the cholesterol stones is what we're doing. And ursodiol works by reducing cholesterol saturation in the bile, and it inhibits cholesterol synthesis that improves the flow. So ursodiol is going to be your hydrophilic bile acid that dissolves the cholesterol gallstones in those who are unwilling or unable to undergo a cholecystectomy. So it describes the cholesterol synthesis in the liver and improves cholesterol solubility in the bile. So they have cholesterol gallstones without inflammation, and that makes them a big candidate for ursodiol because ursodiol works by inhibiting hepatic cholesterol synthesis, and it lowers the cholesterol saturation in the bile and allows gradual dissolution of the stones. So increased water absorption in the small intestine, that describes the laxatives or antidiarrheals. That's going to be our statin. So statins also inhibit the cholesterol synthesis, but they do it by blocking the HMB-CoA reductase, which is the rate-limiting step in cholesterol. So it's similar to ursodiol, but it's different, right? They both affect hepatic cholesterol synthesis, but they do it like in different ways with different goals, right? Statins, the target is going to be serum LDL cholesterol, and the main use is for hyperlipidemia in statins, whereas ursodiol is going to be bile composition, right? So the gallstones and dissolution is ursodiol. So I think this is more indicating like ursodiol than it is a statin. However, they're both going to be inhibitors of cholesterol synthesis. They're going to stop the synthesis. And so this is really about reducing the hepatic cholesterol synthesis as part of making the bile less lithogenic. And so gallstones can dissolve. So yeah, statin's totally good, but C is not necessarily going to be a statin. This is ursodiol, which reduces the bile cholesterol content. And the answer is indeed C. Reduces cholesterol absorption in the gut. What's that about? So if you're reducing in the gut, that's acetamide. That's going to lower the serum cholesterol, not the bile concentration directly. If you want to change the bile concentration directly, then you're going to use ursodiol. But if you just want to decrease the absorption, then you're going to think ezetimibe. How about decreasing cholesterol synthesis in the bile? Well, that's partially true, but it's not the primary mechanism for stone treatment. And also check this out, guys. I haven't showed you this, but look, I did some coding last night, and look at that. And look at this. I made it so that each question generates like this. What do you think of this new layout? Because what I plan on doing is I plan on releasing these questions to Ivy Med, where you guys are going to be able to interact with it just like this. And it's going to have explanations for all these involved. But the thing is, these questions and explanations are generated with GPT. And so I don't really trust them fully, because what you guys get when you're working with me in the live stream is I've trained these models so that they're more accurate than most. And also I'm able to fact check them with my own knowledge. I plan on later down the line making a nice interactive kind of mechanism here. And you guys can see on the notes, it says, decreased cholesterol secretion. The key test is CT shows gallstones. The differential is cholesterol pigment stones. The associations are gallstones and obesity. The memory is cholesterol. C is for cholesterol. Don't confuse it with acids question. So it's kind of cool how it's going through these notes, but all these things are coming, right? And I'm actively coding and just trying to maximize the use of my time. I hope you guys can kind of feel how I'm really trying to make this improved for all of you guys. And I really want you guys to just do super well on this exam. So yeah. And if you're watching on YouTube later, of course, if you can like and subscribe, and if you want to support this mission, because right now I'm just coding all this stuff whenever I have the free time, but then it would really help if you want to be a member of the channel in some way. I think it's $3 or something to join, at Stardos or something like that. But here we go. We have a 62-year-old man presenting to the clinic with persistent left-sided burning and tingling that began 4 months ago. He describes the sensation as unrelenting with intermittent severe pain. 6 months ago, he experienced a cerebral hemorrhage, which temporarily affected the right upper lobe and the left extremity coordination. MRI at that time revealed an intracerebral hemorrhage in a specific brain region. On current examination, he has a decreased sensation and light touch temperature on the left side, but muscle strength are intact and reflexes are intact. Gentle brushing of his left arm results in a significant discomfort. The ongoing symptoms are most likely to damage which of the following areas? Yes, he has persistent left side burning and tingling. He's got chronic neuropathic pain and post-stroke stuff, so definitely thalamus. So I'm liking how you guys are both saying thalamus. That's indeed the correct answer. And so if I were to draw this out on a little brain, so here's our brain, here's our head. Actually, let's just say that's our brain. And we have kind of hard to draw all this stuff out. Where would the thalamus be located? Right around there. Chest noob, welcome back. Yeah, the thalamus. All the sensory stuff goes through the thalamus. Very nice. Except the vision. So persistent left-sided burning and tingling. There's some sort of a neuropathic pain syndrome. And also there's unrelenting intermittent severe pain. So gentle brushing can cause significant discomfort. And so that's going to be a post-stroke pain. And you have cerebral hemorrhaging with sensory loss and intact motor function. So that's going to be thalamic involvement, especially the ventral posterior nucleus. There's also decreased sensation to light touch. And so both the spinothalamic and the dorsal column pathways converge in the thalamus before they relate to the cortex. So the pain after the stroke syndrome. So this is going to be in the thalamus, disrupting the sensory problems, because usually this is after an injury to the ventral posterior lateral and the ventral posterior medial nuclei of the thalamus. And these nuclei can relay somatosensory input to the cortex. When they're damaged, they misprocess, do exclamation mark symptoms, and it'll say the symptoms that he's experiencing. Okay, so post-stroke pain symptoms in the thalamus, knowing where the thalamus is important. Okay, and then just above this thalamus here, caudate, the caudate nucleus, and this would be Broca's area. This would be the primary visual cortex. And so the sensory symptoms that are involved the entire contralateral part of the body. And we'll go on to our next one after we do this. So the persistent left-sided sensory symptoms post-hemorrhage indicate thalamic damage affecting the sensory pathways. All right, what are you guys chatting about? Sensory stuff in the thalamus except for olfaction and smell? Yeah, so it sounds like you're just kind of thinking out loud through the visual pathway. Basically, the visual pathway is going to be retina. So you start with the retina, and then you go to the optic nerve, and then the optic chiasm. And there you have the nasal fibers, that's where they cross, and the temporal fibers, the lateral retina stays ipsilateral, but the nasal fibers cross. And then that results in the left visual field in the right brain and vice versa. And then you have the optic tract after that carries the contralateral visual info. So optic is always contralateral. Then you have the lateral geniculate nucleus of the thalamus, and that's the replay center for visual info, the lateral geniculate nucleus. And then there's optic radiation. You have the Mayer's loop, which is the temporal lobe, and that carries the superior vision field. Mayer's loop, temporal, superior. And there's the Baum's loop, which is the parietal lobe, and that carries the inferior visual. And then you have the primary visual cortex and the occipital lobe, and that's the final processing where that occurs. And so if you have an optic chiasm lesion, that's going to be bitemporal hemianopia. So a pituitary tumor is going to cause bitemporal hemianopia. Optic tract lesions are going to be contralateral hemopinous hemianopia, and that's going to be the pie in the sky. So Mayer's loop is the pie in the sky. And then the Bombs loop, parietal lobe, it's contralateral inferior quadranopia, adrantanopia, and then visual cortex lesion is going to be with macular sparing. So contralateral hemianopia with macular sparing. So the PCA stroke is involved there. Okay, so here's our next question. All right, so here we go. A 45-year-old woman has a history of chronic obstructive pulmonary disease, presenting to her primary care physician with unintentional weight loss, fatigue, and intermittent fever over the past month, persistent cough, and she immigrated from Southeast Asia 15 years ago. Temperature is 100.6, crackles in the apices of the lungs. A chest CT reveals areas of consolidation and fibronodular changes in the upper lobes bilaterally. A sputum sample is obtained. An acid-fast test is positive. The sample is sent to mycobacterial culture. How long does it take for this type of culture to yield positive results? Yeah, pretty just like factoidy question here. So, but the weight loss, fatigue, the fever, and the chronic cough, that's reactivation tuberculosis. And then they immigrated from, gotta decline that real quick. Emigrated from Southeast Asia, that's tuberculosis endemic area. So the Southeast Asia makes you think of tuberculosis as with like a prison. Weight loss, fatigue, intermittent fever, and chronic coughing. And also the apical fibronodular consolidation, that's going to be reactivation TB. The fibronodular consolidation. Acid fast also confirms that it's Mycobacterium tuberculosis, and there's a Mycobacterial tuberculosis, so we just know that this is tuberculosis, right? And you mentioned that you think this is taking a lot of time. Mycobacterium tuberculosis does grow very, very, very slowly, and you just have to know that this is 2 to 4 weeks. Slow growth is due to the mycolic acid-rich wall, and that limits its replication speed. It limits the speed. Okay, these 4 to 10 days would be the fastidious organisms like a Haemophilus influenza, Legionella, and tuberculosis just has a specialized media and it takes longer to incubate. So that's not it. And that's all there is for this question. So positive Mycobacterium culture typically takes 2 to 4 weeks in a suspected pulmonary tuberculosis cases. Also, I checked the geography and I think 68% of the population is actually from the United States. And then the next biggest country is actually India. Pakistan is, I think, like 4th or 3rd. But we have 5,000 recurring viewers every month. All right, on to our next question here in a second. All right, so here we have a 33-year-old woman presents to the emergency department with severe right-sided flank pain that began suddenly while she was at work. She describes the pain as sharp and intermittent and is associated with nausea, but no fever. And we have a blood pressure of 130 over 85, so it's elevated, and you guys can see that accurately reflected over there. And physical examination says right flank pain, tenderness, and otherwise soft abdomen. Urine analysis reveals microscopic hematuria. She's diagnosed with a ureteral colic due to suspected stone. The pain is radiating where? Okay, thanks for voting. Everybody cast your votes in. Okay, so yeah, anatomy questions, always tough. So we have severe right-sided flank pain that began suddenly, and that is going to lead us to think that it's renal colic from ureteral obstruction. There's also some sharp intermittent pain and nausea, and so that's going to be spasms and visceral pain, and there's microscopic hematuria that's common with kidney stones and also mucosal irritation. So you have right flank tenderness, and that's going to tell you that if it's right flank, maybe you have some upper urinary tract involvement, and there's also going to be some radiation, and we have to know where. So the stones are going to trigger colicky pain that goes from the flank to the groin. And so it follows the T11 to the L2 dermatome, and that's going to reflect those shared visceral sensory shared visceral innervations. All right, so the answer is going to be C. It's the right groin. So renal colic from a stone causes the super sharp pain that radiates from the flank to the ipsilateral, same side, groin as the stone moves down the ureter. And it follows the genitofemoral and the ilioinguinal nerve. And that corresponds to the T12 to L2 dermatomes, and that's why it travels toward the groin area. It's because it's following the genitofemoral and the inguinal nerves. Right shoulder is referred pain from the diaphragm. Left upper quadrant of the abdomen is going to be like the spleen and gastric pain, so definitely the wrong organ there. The right knee is with a sciatica or a referred musculoskeletal pain. And the neck is for myocardial infarction or a cervical spine pathology, something like that. But the ureter is retroperitoneal, and it's a muscular tube that carries urine from the kidney to the bladder. And if you have a stone, it'll descend and it causes colicky pain that corresponds to the visceral afferent fibers, which share spinal roots with the somatic dermatomes from T11 to L2. And so the pain is going to be felt in the flank and costovertebral angle, and so the pain is shifting inferiorly toward the groin, the labia, the scrotum, depending on the anatomy. Yep. So, and the colicky pain, by the way, it's like very sudden. It's episodic, and it comes in waves. And so kidneys, intestines, you could have intestinal colic. You could also have a blockage of the gallstones and the kidney stones. And yeah, so that's what it means by colicky pain. Okay, right shoulder, diaphragm, left quadrant, splenic, and also left kidney. Left quadrant of the abdomen. It would be splenic. And the neck, cervical. Moving on. A 52-year-old homeless man is brought to the emergency department by a social worker who found him wandering the streets disoriented with staggering gait. They cannot provide a coherent history, but says that he's seeing double beauty when looking to the side. There is no evidence of focal weakness, and blood alcohol is found to be 0.02. The attending physician suspects a nutritional deficiency and orders lab tests. Which of the following interventions is most appropriate initial step in management? Okay, the most appropriate initial step in management. Yep, give thiamine. And then a way that they could ask this as well is, so let's do that now. Don't you know where the mammillary bodies are? Right there. Let's find a better image. There's a little mammillary body right there. Oh, you can't see it because the chat's in the way. Mammillary body, substantia nigra, mammillary body. There's the mammillary body. Ooh, look at that. Look at those mammillary bodies. That's a perfect image. Check that out, guys. Mammillary body. There it is. There's a mammillary body. All right, so here's this next question. We have a 45-year-old man presents to the emergency department after experiencing a sudden severe headache followed by nausea and vomiting. History of poorly controlled hypertension, and on examination he has right-sided ptosis and his right eye is fixed down and out. Left eye, both pupils constrict. However, when it is moved to the right eye, the right pupil fails to constrict. Not reactive to light. So what happens when it's observed when the left eye is shined? When the light is shined on the left eye. Okay, the votes are in. All right. So we have a sudden severe headache, ptosis, and eye down and out. We should all be thinking of cranial nerve 3 palsy. Now, the right eye is failing to constrict to light, and so that means that there's some sort of parasympathetic fiber involvement in cranial nerve 3. You're not constricting to the light like you should. So parasympathetic involvement. The left eye light causes the both of them to constrict, and that means the afferent limb and the contralateral efferent are still intact. And so there's an ocular motor nerve palsy, not optic nerve lesion, which would affect the afferent limb. So there's blown pupil and down and out eye. So ocular motor is 3. That's causing the eye to be down and out. And also you have a dilated, non-reactive pupil. And that's caused by a posterior communicating artery aneurysm or hypertensive midbrain hemorrhage. So the right ocular motor nerve carries both the somatic motor fibers to most of the extraocular muscles and also the levator palpebrae, and also the parasympathetic fibers to the pupillary sphincter. And so if you have a lesion there, it causes ptosis, which is down and out, and also pupil dilation that does not react to light. And when the light is shown on the left eye, which is the normal eye, you have the afferent limb that triggers bilateral constriction to both of the cranial nerve 3 nerves. And so, but since the right cranial nerve 3 is damaged, the right pupil remains dilated while the left one constricts normally. And so whenever you're shining them into the left eye, then both pupils are going to appear to constrict equally, but the right is going to be fixed and unreactive. But yeah, they're both going to constrict equally. So the answer is A. Basically, if a pupil is not reacting to light, then you should think of cranial nerve 3 compression, which is due to posterior communicating artery aneurysm and uncal herniation. If a cranial nerve 3 parasympathetic fiber runs superficially, and it's going to be compressed first probably because of how superficial it is. Got the afferent cranial nerve 2 sensing the light, and then the efferent cranial nerve 3, which is the parasympathetic fiber, and it constricts the pupil. So you shine the light on the cranial nerve 2, totally good, and it reaches the Edinger-Westphal nucleus, and then both the cranial nerve 3 sends a parasympathetic to the pupils. And then the right cranial nerve 3 is damaged, and so the right pupil doesn't constrict. The left one will, if the cranial nerve 3 is damaged. Also, they could have like a thunderclap headache, drooping eyelid, that stuff, and the right eye is just frozen down and out. Well, thank you. All right, Dr. Moise, thanks for joining. Thanks for coming along. Anytime that somebody shows up and they got a really bad headache and they have droopy eyelid, they have the ptosis, and the eye is stuck looking down, and there's a big old pupil that does not shrink in the light, then all of that makes you think of a cranial nerve 3 palsy on the right side. In cranial nerve 3, it moves the eye most directions, and it also lifts the eyelid, and it also makes the pupil smaller. That's the 3 things that cranial nerve 3 does. Moves the eye, constricts, and also lifts the eyelid. Moves the eye, constricts, lifts the eyelid. And so if you shine light in the left, then the left has cranial nerve 2, which is the optic nerve, sees that light, then the left cranial nerve 3 is working, the left pupil is going to constrict, and then the right cranial nerve 3 is broken, so the right pupil doesn't move. And so, but since you're only watching the left eye, it constricts like normal, so it looks like both pupils are responding fine. All right, moving on to the next question. Let me check on the code real quick. Okay, this one has the answer. All right, so you can see the answer in this one, but a 45-year-old man has type 2 diabetes and a history of alcohol use disorder presenting for routine checkup. He reports drinking moderately now, but acknowledges that heavy drinking in the past affected his liver function. He expressed concern about his drinking habits and mentions that he has been thinking about completely stopping. So he's just thinking about it, so he's just contemplating it. He's thinking about actually stopping. Pre-contemplation is not even thinking about it. Preparation is like, I got a plan. Action, you're making changes, and maintenance, you already done it for 6 months. Easy. Next question. All right, what do you guys think for this one? Oh, thanks. Thank you, Kushbu. I really appreciate it. That's nice of you to say. Yeah, I'm glad you could Glad you could join in the future and hopefully have a restful night. So let's do this question together, shall we? 15-year-old boy presents to the emergency department, has a 3-week history of involuntary movements. Now we have to see if there's any strep stuff. Not complete the course of antibiotics. Yep. Jerky movements and also apex and axilla. We have fluctuating muscle tone and coordination of the right arm. What's going on? So 15-year-old, typically this is going to be in children and adolescents. And so this is definitely making us think of chorea. Also, he has some involuntary movements in his right arm. The facial grimace, which is classic for chorea. Change in the mood is also common. And strep throat. There it is. Sore throat of 2 months ago. So he's got the group A with incomplete antibiotic use. That's the giveaway. We also have mitral regurg, which is common in rheumatic heart. And there you go. Mitral regurg, sydenham chorea, just kind of classic signs here. Myasthenia gravis out of fluctuating stuff. Parkinson's resting tremor. Tics and stuff for Tourette's. And essential tremor would improve with alcohol and a bilateral fine tremor. All right, here we have a 34-year-old woman. We can see the answer on this one, but presents to the clinic with a 2-week history of persistent abdominal discomfort. And she went from a hiking trip in the Appalachian Mountains. Physical exam shows stool analysis and diagnosis of Giardia. And she has a medication which targets primary pathogen causing her disease, her illness. Which of the following mechanisms of action is associated with this medication? All right, well, she's on Giardia, so we just have to know which medication is going to work on that. And it's metronidazole is the answer. So it's a disruption of the protozoal DNA synthesis, because it's on metro. So Giardia causes greasy foul diarrhea, treats by damaging the protozoal DNA. And Giardia is a flagellated protozoan. You have to recognize what that looks like, the kind of like weird freaking pear sheep shield look. Opening of the ligand-gated chloride helminths. So that's the ivermectin, is opening of the ligand-gated chloride channels used in parasitic worms. Binding a ribosomal 30S subunit is aminoglycosides and tetracyclines. Binding a protozoal tubulin would be albendazole, and inhibition of dihydrofolate reductase, trimethoprim. That's used for toxo and plasmodia, not giardia. Toxo. 34-year-old woman comes to the clinic due to a 3-month history of progressive worsening dysphagia from solids and liquids, along with occasional regurgitation of undigested food. She reports unintentional weight loss, and medical history is unremarkable. She's not taking any medications. Physical exam reveals normal vital signs, and esophageal mammometry study shows high resting pressure and incomplete relaxation, coupled with lack of peristalsis. What is the most likely cause of this condition? So she has progressive dysphagia to liquids to solids. So this is probably like a motility disorder because it's progressive. It's probably not mechanical. There's regurgitation of undigested foods. That's achalasia, not cancer necessarily. And there's mammometry shows an increased lower esophageal pressure, and there's also absent peristalsis, and so that's also achalasia. And this is going to be loss of inhibitory neurons of the Auerbach plexus. So the answer is B, loss of inhibitory neurons of the Auerbach plexus. Let's talk about the other ones. Dorsal motor nucleus of the vagus. That's the parasympathetic output of the visceral organs. That would cause widespread GI issues, so no. Hyperactivity of the vagus nerve affecting esophageal contraction. That would not be responsible for any esophageal peristalsis or low esophageal dysfunction. Hypothyroidism leading to slowed gut motility. Hypothyroidism. So hypothyroidism, that would cause like constipation maybe, or it would cause constipation, not isolated esophageal motility. So that's why it's not E. Hyperactivity of the vagus nerve. That'd be, achalasia is just the loss of inhibitory. So it's just not the right mechanism. Absent peristalsis is achalasia. Compression of external mass would have dysphagia starting with solids, not both simultaneously. You have the bird's beak, dysphagia for solids and liquids, high LES, Auerbach plexus. We've been going for far too long. So we have a 32-year-old man presented in the clinic after 3 years of infertility despite having unprotected intercourse with his partner. And we look at the sperm count, it's super low, and they have an increased venous flow. So which of the following is an additional observation? Okay, answer is going to be elevated intra-abdominal pressure. So we have the swelling of the hemiscrotum. That's a left-sided varicocele. And that infertility stuff is with the varicocele because the thermoregulation gets out of whack. Increased venous flow to the left pemphiform plexus is going to be a varicocele and Doppler ultrasound. Back discomfort suggests nutcracker syndrome and increased intra-abdominal pressure. B is correct. Good job, Damien. Well done, well done. Swelling in the left hemiscrotum. Oligospermia, less sperm because of the overheating and venous pooling. Increased venous flow, hallmark of varicocele, and worse withstanding gravity increases the pressure in the left renal vein. So the intra-abdominal pressure is really the takeaway. Here's the bottom line. Varicocele characterized by increased venous flow and often presents with oligospermia and normal testicular size. And if you're watching later on YouTube, then be sure to like and subscribe.